All right, we're going to go ahead and get started, you guys, so that we don't have to be here too late. The whole point of this talk is there is not anything miraculously new in CPR, but I really think it's important that we're all on the same page as to how we're doing CPR. As I think Danielle had said, depending on what location you are in the hospital, if you're in the ICU or in emergency and critical care, oftentimes we are doing CPR on a daily basis, and so it becomes routine for us. But there are new individuals that are coming into our team that have not done CPR, or at least not in the frequency that we do it in the ER. And then there are other people from other departments that may get into a situation where they need to be part of the CPR team. And when we talked about this as a critical care team, ICU, we felt like it'd be the best approach to have Mallory, one of our ICU nurses, talk to you guys about CPR and get the discussion from the perspective of a nurse. Because a lot of times I think that it's easier for you guys to learn that way and absorb that information when you're getting it from their perspective. And a lot of times for us as doctors, we're coming in and yes, we're the leader in the CPR code, but a lot of times, we're shouting out orders and getting things done, and sometimes it's hard to process what all that stuff means, because you're nervous and everybody's kind of running around. And so part of this discussion really is to remind everyone the worst has already happened. So the patient is already in this scenario, stopped breathing, or it has gone into cardiac arrest. So the biggest thing, which I know is so hard to do sometimes for us too, is to not get worked up, not freak out. One of the things I've seen people do, especially some of the newer people, is they grab that crash cart, and you guys know that crash cart is that big toolbox, and I've seen several times now in the past few months that crash cart starts to fall, and it's like a huge, heavy toolbox, and I don't want people to get hurt. So maybe don't walk the toolbox, but maybe slowly bring the crash cart over and not be in this oh my God, the plane's on fire approach. Because the more that we do this and the more routine we are about it, the other thing that you probably have heard me say when we go through and we debrief about CPR is that every time we do CPR, it's a practice for those patients that we can get back and for those patients that we should get back. Does anybody have an example of one of those patients where we as a team need to be ready to go and on board? And we actually had one yesterday that did not code but almost coded.
Post-op anesthesia?
Yes. So post-op anesthesia, intra-op anesthesia, even pre-op medications. Those are the really big CPR codes where we really should be getting those patients back. And that's probably the most common one. Research behind it, usually they say about 50%. I would like to think that we're higher than that and that we're prepared for those cases. And we have had other trauma cases where we have major bleeding patients and we're doing CPR and transfusing those patients, a massive transfusion at the same time, and we've gotten those patients back too. So although we do have some of these chronic patients that are 15 years old and they come in for heart failure and they cardiac arrest and their owner wants CPR, we really should, and I know sometimes it's hard for us, we need to take those cases seriously as well, because that case, even though we may not get that patient back, it's learning how to work together as a team, making sure everybody knows their role, and everybody being ready and on board when we have a patient that we may be able to get back successfully. Okay, so Mallory's got a lot to go through, so I'm going to be quiet for once and have her talk, and if there's any questions, then I'll sit in the front row.
Oh, geez. So if at any time during any of this, you guys have any questions, any comments, anything to clarify, please let me know. We'll go through it at that point. We won't do all the questions at the end kind of thing, as long as it's not a crazy question. So for those of you guys that don't know me, my name's Mallory. I'm one of the critical care technicians. I've been here for a really long time. I think 13 years this past fall, so a really long time. And like I say when I go over this presentation, in the past, CPR and critical care and emergency medicine is all I know. So for those of you that came from day practice, or those of you that don't have any experience in the veterinary field, that was me. You're so naughty. That was me too. I came in as an assistant, and I had absolutely zero veterinary experience until I came here. So I'm sure many of you guys have heard about Recover, or heard the word, or heard the phrase. What it actually means, it's not just a random word that sounds like it goes with CPR. It's actually part of an acronym that was put together by those with the Emergency and Veterinary Critical Care Society. And it's basically sort of like an overview, a very, very thorough look through all the data that we have, lots of surveys with veterinarians, lots of information gathering. And they put together basically their own standards for CPR. So what we found has the best outcomes, and they sort of spread that information to make CPR a little bit more standardized. Prior to Recover, there really wasn't anything like that. They have it in human medicine certainly, and they're certainly far ahead of us, but we didn't have anything like that in veterinary medicine. So preparedness and training certainly is the whole reason why we're all here. It's really important to know what you're doing before you actually do it, so that you're not in a situation where you're running a code with someone and the rest of your team and you have no idea how you can be helpful. So the other really important thing is that hands-on practice is really, really, really important. And I feel like you guys can, or anybody, could read how you do CPR, all the information, all of the steps and things to keep an eye out for. But once you actually get in that situation and you've never put your hands on a dog or done chest compressions or a cat, and you're in that situation, it's terrifying. So make sure, especially if you guys aren't comfortable doing it, please make sure that you put your hands on the model. So as far as a code status, we're going to start from like the very beginning as far as our hospitalized patients, right? So every patient here in the hospital should have a CPR code. So for those of you guys that are going over estimates with owners, I don't care if they're staying for like an ultrasound for 2 hours and then they're going home, please, 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 please get a resuscitation code. It does not have to be the owner's final answer, but it just gives us a few minutes head start, to get started if something should happen while the patient's in our care. As far as the code status, it should be clearly marked on their cages, and I feel like we do a pretty good job of this. However, I will say that something that I've run into is, for example, Sam, was this patient a resuscitate? Yes, it was, but actually it wasn't. So please, please, when you guys, if you're the one filling out these cards, please look at the actual estimate that has the owner's signature on it and it has their choice, so that we're not accidentally either doing CPR for a patient whose owner doesn't want it, or vice versa. Emergency drug sheets as well. These are pretty important. I feel like aside from emergency doses, the other thing that's really important on these, which is kind of hard to see, is it this one? There are reversal doses right here. So if you guys have somebody like the other day that was on dexdomitor or something that got a morphine derivative, all of your reversals are right there on this sheet. So you don't even have to, it's like brainless, super easy. There are obviously also the emergency drugs on there as well. I feel personally that every patient should have one. I know that there's some thought that DNRs don't necessarily need them, but say the patient, like yesterday or the other day, that patient may have been a DNR, but that doesn't mean that we shouldn't have reversed it. So the crash cart, like Dr. Hollihan said, I'm sure you guys have all seen it. It's right next to the elevator. Everything that you need for a CPR code should be in this crash cart, and it is in our case, so that's great. It's really important that the tape across the front is basically, if you guys don't know, what that means is that someone has gone through the crash cart, they've done the full inventory, they know that every single item that should be in there is in there, it's in the appropriate place, it's workable, it's functional, it's good to go. When the tape is off, that means that someone has taken something from it, so whatever you may need might not be there. So there's 3 aspects technically of CPR, and the first 2, basic life support and advanced life support, are what we're going to go over tonight. Post-cardiac arrest care, those are all those really critical patients that are in the sink in the ICU. So, Ashley, here's your butt. So just to give you guys an idea of what advanced life support looks like, it's like a whole team effort. I think Ashley's doing chest compressions, Dr. Fidel and Dr. Ricketts, I think, are just there for moral support.
They're there for moral support.
Christina's down on the bottom doing ventilation. You can sort of see Kara right here. She's recording. Jamie's getting the defibrillator, or Hala's getting the defibrillator ready. And Jamie's getting ready to...
She looks like she's got some gel.
Yeah, she's getting ready for it.
Coppins is making sure that you're doing compressions correctly.
Yeah.
Which is not a bad thing. That's actually something that we do all the time, is assessing everybody's compressions when we're doing CPR. And you'll often find us, if an owner says they don't want to stop, for whatever reason, and we have a 20-minute CPR code that we're running, we will purposely make sure that the new people are cycled through so that they can practice compressions as well. And then we'll go into this, but the end-tidal CO2 monitor out to try to help evaluate your compressions, and we'll do a couple other things to evaluate compressions. And it's nothing against you guys, it's not to single you out, it's just so that we can all get better about doing compressions better. I mean, I know there's certain people on our team, like we always joke around that Don and Sasha and some of the other people have done CPR often, they can always get really good end-tidal CO2s because they do really good compressions.
Got the groove.
But everybody needs to be part of that team too.
And the other thing too is I've seen Dr. Coppins do it with, have a lot of new people or those that aren't terribly comfortable with CPR do compressions on patients after CPR has stopped, just so you have the feel of it. So a really brief idea of what post-cardiac arrest care looks like. Like I said, these are the sync patients or the floor patients that have every hole has a tube kind of thing. So basic life support is obviously where we're going to start. And this is very simply put, just recognizing that arrest has happened, starting your chest compressions and starting your ventilation. And basic life support is what anyone can do. It doesn't have to be in a veterinary setting. So the patient evaluation should be very quick, right? So just a few seconds. If you guys have any question whatsoever in your mind that that patient is gone, not breathing, doesn't have a heartbeat, don't spend a minute and a half seeing if you could hear their heart with don't run to go get your stethoscope and come back and just make sure, just start with basic life support. In previous recommendations, we used to do an ABC assessment, so airway first, then breathing, then circulation, meaning making sure their airway isn't obstructed, make sure that they are or are not breathing, and then address the heart. But actually we've revamped it as well as human CPR as well, so circulation becomes your primary concern always. The consequences, as I'm sure you guys know, of delaying basic life support are huge. So you have a lot of tissue damage even within just the first few minutes. So getting the blood circulating and hopefully oxygenating that blood is really important. Another side note too, I don't want you guys to ever feel like starting CPR I don't feel like you're ever going to do more harm than good, because like Dr. Hollihan said, these patients are already gone, and the only thing that you can do is help. The small percentage of patients that do have any kind of serious harm when basic life support is started is probably something like, I don't know, ITPs that need CPR, or maybe rib fractures or other stuff that you have no control over. So like I said, minimizing the delay is really important. There's a lot of tissue damage really quickly. So when addressing and evaluating your patient, I definitely recommend just checking the chest wall. If you have your stethoscope on you, that's great, just listen. If you, like I said before, if you don't have it, please don't run to go get it, but just feel their chest wall. It doesn't have to be an exact science. The other thing to keep in mind is that if we were probably to get femoral pulses on our patients in the hospital who are hypotensive, there's probably several of them who don't have femoral pulses and obviously are not in cardiac arrest. So using the femoral pulse as an indicator as to whether or not your patient has experienced arrest is not terribly reliable. And it's harder, especially if they maybe have a heartbeat, but they have really crappy blood pressure because they're about to die, so that sort of thing. Use the chest wall. And like I said, when you're in doubt, just start. So breathing, I feel like this might be the easiest thing to see if we're just walking past a cage and we're like, I don't think that dog's breathing. So this might actually be one of the first things that you notice isn't quite right. But obviously just make sure that, or check to see if the chest is rising and falling, obviously. Is there anyone here that's not familiar with agonal breathing? Please be honest. Everybody's cool? Okay, so the reason I ask that is you could see a patient who technically has not arrested, their heart could still be beating, but they're experiencing something like this, agonal breathing, which is like a really sad looking, gaspy type of breathing. And if that patient hasn't already arrested, they are about to. So a really important thing to keep an eye out for. So now we're gonna get into the actual specifics of CPR. So your compression rate should be about 100 to 120 beats per minute. And as we'll practice later. There's a perfect song, which I'm sure you guys have heard about this. Staying Alive is perfect as far as the timing goes, but it's not the only. You guys can Google, and there's like a bajillion songs that fit the tempo, so pick your favorite, whatever you guys will remember and whatever sticks with you.
One of the other key points here, Mal, that we had come up a couple weeks ago was this is the same for dogs and cats. So that was something that had been a question for everyone. So everything that Mallory's going through on these compressions as far as the depth and everything is same for cats as it is for dogs.
Even though there's a cat picture there.
Yeah.
So full elastic recoil of the chest is super, super important, right? So you're gonna squash the chest with your compression, and you gotta make sure that you actually let the chest completely expand before you start to squash it again. And sometimes that might mean, if it's easier for you, actually taking your hands, I don't wanna say off the patient, but completely releasing all of your pressure. Because allowing the chest to completely recoil is what's actually allowing everything to refill. Your compression depth is going to be about 1/2 to about 1/3 of the chest wall, depending on the compliance of their rib cage and things like that. Honestly, if you guys are like the best, absolute best chest compressor in the whole wide world, you win awards for it, you're awesome. You are only going to get 25 to 30% of their actual cardiac output with chest compressions. And it's not anything that you're doing wrong. So just keep in mind that it's really important to keep chest compressions going, because even with all of our efforts, we're barely even getting much of anything. Compression cycles. I do feel like this is something that we can improve on. I do think that we're really good at rotating compressors and doing it very like in a fluid motion, and one person's sort of like counting off as they're stepping off the stool, and one person's stepping right on. I feel like that's very fluid and we do a really good job. But I don't think that we always do 2-minute cycles, and I think that's really important. And I understand if you guys have never done chest compressions, or even those that have, you are exhausted and your arms are burning and it's terrible, you're sweaty. So the 2-minute cycle thing, the reason it's so important is that from doing cycles too long, obviously you get really tired, you start to lean into the patient, so your chest compressions kind of start to suck a little bit. So your compression quality goes down. But from the other end of it, doing compressions too short, or cycles too short, it takes 30 seconds for the maximum output to be achieved, right? So you've been doing compressions for 30 seconds and then you switch. So your output's like up here, and then you switch and you're back down here. And you gotta wait 30 more seconds, roughly, to get back up here again. So that's why that's really important. And like I said, I feel like we could do a little bit better than that. I don't think we ever have like a timer or anything like that. And I don't know that it has to be that strict, but I do feel like people get tired and they're like, okay, who's ready to switch? And I feel like that could be a little bit better.
That'd be something like every quarter, the person who's doing the recording.
Yeah,
Say 2 minutes.
yeah, that'd be great. So there's two theories as far as how chest compressions actually get the heart working. I shouldn't say working, blood flow through the heart. So the cardiac pump theory basically just means that you're squashing the heart, and then as it re-expands, you're refilling those chambers, squashing it, shooting it out continuously. With the cardiac pump theory, you'll be doing the chest compressions right over the heart. The other theory is the thoracic pump theory, which basically means that you're adjusting the pressure within the chest to cause that forward motion of blood flow. And in these patients, your compressions are actually over the widest part of the chest. I think this is another thing that we could do better on. I feel like our instinct and our first choice is always to do compressions right over the heart. And for a lot of our patients, like labs or shepherds or a lot of the really common breeds, we should be doing chest compressions over the widest part of their chest. So I'll go into more detail about that shortly. So as far as your chest compressions for different sizes and shapes of dogs, the little guys, so this could be cats, this could be really tiny foofy things, it's usually most convenient and easiest for you guys to do compressions just like they're picturing, sort of often with one hand behind their back to sort of support it, and your other to do the chest compressions. Again, you're going to be doing compressions right over the heart, and one of your hands, like I said, will be supporting it. Oftentimes you guys will notice that as you're doing compressions, your patient's kind of like scooting across the table. So your hand definitely can help you as well. When you get into patients that are a little bit bigger, here's some little foofers.
when you're doing?
No, they've actually done pretty extensive studies that doing 2 minutes is the maximum across the board, yeah. For fatigue for people and also to maximize the amount of cardiac output you're getting.
I mean, obviously you do definitely get like hand cramps, even if you are using both hands for like something really tiny. But I do feel like smaller ones, the CPR is easier, not using quite as much as of your body. So for guys that are a little bit bigger, the technique is going to be exactly the same. You'll just be using 2 hands. So these are the patients where one hand isn't comfortable. You don't feel like you can get that compression of 1/3 to half of their chest width. So if you feel like one hand isn't enough, you probably need 2, obviously. So again, we're going to be doing compressions right over the heart. I think that's really it. Like the picture of the person here, oftentimes, like I said, with the hand at the back and one hand like this for the really tiny guys, oftentimes it's easy to have the patient's back to you so that when you're pushing, you're not pushing them away from you. And some more of these guys. This beefcake right here definitely is going to need 2 hands. All right, so this is where things get switched up a little bit. And the labs, like I said, German Shepherds, Goldens, a lot of your medium-sized stuff usually is often going to be going to fall under this category. And with these patients, you can see in this picture, the guy's heart is like up here, and he's compressing over basically where his rib cage is ending. And this guy is the one situation where we use that thoracic pump theory. All the others are cardiac. So, tall, skinny guys, greyhounds, Dobermans, poodles, those sorts of things, we jump right back to the cardiac pump theory. 2 hands, once again, and directly over the heart. And here's the, doesn't follow the rules. So in the case of these patients, you're actually still doing the thoracic pump theory. You're still technically squashing the heart, because imagine, I mean, these patients are barrel chested, right? So they're as wide as they are deep. And you're technically, even if you're doing chest compressions on their side, you're still kind of using, their chest is so squatty that you're still doing compressions ultimately over their heart. However, the compliance of their chest on their side is not as great as it is when they're on their back. So you're able to actually do more squashing when these barrel-chested patients are on their back. Still doing, like I said, the cardiac pump theory, still squashing the heart itself. And it does not have to be, yeah?
When you have them on their backs like that, usually our dogs like that have difficulty breathing on their backs. Like if you take a bulldog down for x-rays and you flip them up on their back, they can't breathe. Does this have any effect on how our resuscitation as far as airway is going to go if we have them on their back for that?
Technically, in our situations, they should already be intubated anyways. So I feel like it's kind of it doesn't apply to these guys. But if you were like a lay person doing CPR, I suppose it could.
Is it just because of the brachycephalic aspect of it?
Not necessarily. So from a chest compression standpoint, like this guy's not brachycephalic, but how well do you think you're going to be able to squash his heart if his chest is as wide as it is tall, you know? The breathing?
Yeah.
What do you mean? Okay.
I think this is one area where we could get better as well, because sometimes I think it's a comfort thing where people are comfortable doing compressions with the patient on their side like this, and trying to, when we have specifically those bulldogs, which we have a lot of them, trying to get comfortable with them being on their back and still even stabilizing them, because they're a little more floppy like that too. I think this is definitely going to be a more appropriate chest compression for maximizing your cardiac output.
Well, this is going to be a situation where you need to think, well, if somebody's got to take a minute to get that tube in there.
Yeah.
I can't be trying to intubate a bulldog up on its back while people are doing compressions. I mean, it's
We're
hard
gonna talk
enough
about that.
doing compressions and getting in there on their side.
Well, you're going to
Yeah.
have to.
So
You're gonna have to. You're gonna have to practice some more.
And that's okay though. That's a good point. I mean, we can start compressions on the side. They can be intubated, and then the next compressor, we can flip them.
So this is something that we don't actually do a whole lot here, and I'm not sure about how your feelings about how effective it is, or if there's a good reliability of seeing greater outcome in patients that we do this with, but I just want you guys to be familiar with the idea. So basically all it means is that one person is doing chest compressions and the person over here is literally doing like abdominal compressions. So the idea is that you're squashing the chest, you're squashing the blood out of the heart and to the rest of the body, and then down here they're squashing the abdomen, so they're squashing it out of the body and back into the heart and back and forth and back and forth. So it's supposed to, in theory, maximize your blood flow throughout the remainder of, throughout the entire body more effectively. But I will say it's hard. So your timing with the other person has to be like spot on, otherwise you're gonna really mess each other up. And like I said, I don't know how.
Yeah. You can't look at the other person's compressions at all when you're doing that, because oftentimes what ends up happening is your brain wants to match
Follow them.
them.
Yeah.
And so we will add this on if we have prolonged CPR, and or we also have the number of team members to allow to have another person doing the compressions. And sometimes you may see like one of the doctors doing the abdominal compressions while one of the nurses is doing the chest compressions. But it's not something where it's like, oh wow, this adds 20% to the cardiac output. This is just an add-on, more of like an adjunct.
Breed dogs, I could see
Yep,
making more
exactly.
sense than something like this, but-
You're just basically increasing venous return to the heart.
Yeah.
By using your pressure increase.
So moving on to ventilation, I really want to stress that you guys should never have anyone stop chest compressions to intubate. You should never ever also have anyone not start chest compressions to intubate. So a couple of reasons. A, as I said, with the cardiac output, even if you're an award-winning chest compressor, you're still only getting that tiny bit, 30% of your normal cardiac output. And if you stop, you're going right back down. You may as well start over. So that's reason number one. But reason number two, the thought is that think about how long we can technically go without oxygen, right? So the idea is, in theory, that if the patient just arrested, they probably have a decent amount of oxygen still floating around in their bloodstream, especially if they're not breathing and blowing it off. Does that make sense? So I don't want you guys to think that ventilation is not an important part of CPR, because it absolutely is, but I just don't want to see you guys stopping chest compressions to intubate something, especially and even if it's a really tricky patient. I feel like you might have something to add to that.
Yeah, I feel like I see that often, because you feel bad because somebody can't get the patient intubated, so you slow down your compressions, or the compressor's watching and trying to like time so they can pause for a minute while the other person is trying to intubate, and unfortunately, you should be completely ignoring the person that's trying to intubate the patient. And this was actually initially done, the research was done in human medicine because of the concern and the risk for disease transmission when a person arrests out like at an airport or a public area. Not everybody had the mask to give mouth to mouth. And what they found is that even just circulating blood flow in a room air situation like this, that it was far more advantageous than getting a breathing tube in those patients. And so that's where the research came from, and we've adapted that in veterinary medicine. And it is still really hard, even for us, because we were initially always taught airway, breathing, circulation. And now, to be honest, it's circulation. Oh, by the way, let's also intubate the patient.
Last time I took CPR, like for humans, it was like,
Yep.
there was no breathing.
Yep.
That was it. It was
No
like
breathing.
Yeah.
weird.
And that's a little different though in people, because people arrest usually because of arrhythmias. Most people will have cardiac arrhythmias that oftentimes we're trying to maximize the cardiac output for those patients so that we can get them to a point where we can defibrillate them. In dogs, there is some research that some of our patients can respiratory arrest and or have severe respiratory disease and need assistance there. So you should still be trying to intubate these patients, but it should never be our first priority. And I think sometimes we all see people kind of stop and like they can't get the patient intubated, and then they're on their side, and there's that
It's
whole
hard.
It
is hard.
It is a
Maybe like
technique.
in the case of the bulldog who can't breathe anyway, getting, you know, his mouth open and tongue out. If
Yeah.
you can't get him intubated, at least somebody, if they're holding it open, will.
Yeah, and I always try to do for me, it's kind of like, let's say Sam's trying to intubate, she's having trouble, she tries once. Second time around, if she tries the second time, she can't intubate, then we're swapping somebody out. Somebody else gives it a try, or one of the doctors swaps in.
A good practice tool too is when you have to, I'm sure you guys have heard this before, anesthetize something for something routine, intubate them on their side. So I realize it's not the same, right? Because the patient's not jiggling around and they don't have all this fluid coming out of their mouth. But it makes it a little bit easier when you're like in the habit of doing it from their side and how their anatomy kind of like falls, and it's worth getting a little bit more familiar with it. So positive pressure ventilation, this is really important too, and I feel like we're always in the mindset that, oh, more oxygen is so much better, so much oxygen, let's pump it, pump it. So in actuality, you're actually only giving 10 breaths in a minute. So a very, very, by comparison, slow respiratory rate. Your tidal volume will be about 10 mils per kg. Obviously, we're not gonna go above our normal pressure of 20, but thankfully our ambu bags control that for us. So honestly, you guys don't really have to worry so much about this tidal volume. It's just sort of as like a side note for you guys. The 1 breath per 6 seconds is the most important, because I do feel like we're always in the habit of more oxygen is better. The other thing too is that if you're giving breaths and you're sort of holding them for the patient, and not completely releasing the ambu bag, or you're giving a breath and you're holding it for a while and then releasing the ambu bag, believe it or not, I realize that it seems to make sense, right? Because especially if your patient isn't doing that hot under anesthesia and you give a nice big breath, usually you see good outcomes from that. But actually in those situations where you're giving too many breaths or you're giving too deep of breaths, you actually can have impaired venous return and vasoconstriction. So breathe slower. So advanced life support. This is everything that we do here in the hospital, so all the reason why owners bring them to us, all the advanced stuff that people don't have access to at home. IV access, you guys know that that's super important. IV is obviously preferred, and it's usually the simplest. IO for like the little tiny nuggets it's also acceptable, but it's gonna take you longer. It's more challenging to do, it's harder to keep it in place. So there's that, just keep that in mind. I feel like IV is always our go-to.
Everybody in here knows what IO is?
Intraosseous, sorry guys. Into the bone. But also keep in mind that you guys don't have to do, it is easier and more convenient to do their limbs, right? Because their body is being all jiggled around, and at least their legs are like a little bit away from all that, so they can be stabilized a little bit better. But if you guys are having trouble with limbs, you guys can always go to the jugular veins. Always go to the jugular veins. A little bit harder to keep in place, but definitely something that's gonna be bigger and easier to poke.
Can we please get catheters that have rings on the sides for suturing them in once in a while for like?
To just keep them in the crash cart?
Yeah,
For cut downs?
yeah.
Yeah, I
Not
think
just
we could do that.
down, but if we're doing jugular catheters,
Yeah.
It would make it easier.
keep them in without suturing the rings on.
I would say that if the patient has a jugular catheter in, absolutely, that should be where we're giving all the resuscitation drugs, like if it happens to be one of our ICU patients. And then for cut downs, oftentimes the lateral saphenous tends to be the easiest one, I feel, for access for other people if we have 2 people trying to get IV access. But we can probably look into getting some of those into the crash cart, because we've added the trach set in the crash cart since we have had issues with that and wanted to be prepared. And, you know, there's certain things we've added over the past years.
Mm-hmm. Drug therapies, these aren't going to be things that you guys are going to be deciding on when to use or why to use or what have you, but I just want you guys to be familiar with them. So I feel like our most common ones are definitely going to be our epi and our atropine, but I do feel like vasopressin comes in from time to time. Reversal drugs are obviously going to be really important as well. Once you're giving an IV injection of any kind, it doesn't matter what it is, always make sure that you're following it with a pretty big volume flush, right? Because if you're giving a drug to a patient that has like 25 to 30% cardiac output, the drug's gonna like hang out right here for a really long time. So try to flush it all the way in and through. So on all of the drugs here, all these doses that you see up here are sort of the cheater doses and like the quick math doses. And they're all in that table on the handout if you guys have one. So while the actual technical doses are all right here, I feel like this is the easier one to remember. So epinephrine, this one's going to be your vasopressor. So this one's going to have effect on your vasculature, cause some vasoconstriction or basically shrinking of your vessels in an effort to make your blood flow with more pressure throughout your vessels. It's also a positive inotrope, so it's going to affect your cardiac contractility and then also the rate of your heart. We tend to always think that more is better, but it's really, really, really important to start with low dose epinephrine, and that's what this dose is up here. Oftentimes, I mean, the patient's already dead, right? So I don't want you guys to feel like increased doses is going to be better necessarily, because oftentimes we'll find that actually requires more work for the heart and actually can have some detrimental effects, including arrhythmias for those patients. It can be used in situations where we're doing CPR for a really long time. So like, say we've been using low dose right here, or this cheater dose up here, for like the past 15 minutes, 10 minutes, and we're not getting anywhere. It definitely does have a place at that point, but I definitely recommend, as Hala definitely recommends, starting with the low dose. With all of the drugs, especially, they're usually pretty common to be done about every other cycle, so every other swap of rotator. And it's not necessarily going to be an exact science, but it helps sort of in the back of your mind. If you're the one either giving drugs or recording, you'll have your time written down, but usually it kind of just helps keep everything, making sure that you're not underdosing the patient as far as not enough or not frequently enough patients, not frequently enough dosing the patient, or if you're doing it like with every cycle, obviously you're doing a few too many.
Again, that's something if you guys want to read the research on that, it's not like that's something that we've studied or something that we've done. That's when Mallory talks about the recovery initiative, they're getting ready, I believe, to redo it.
I thought it was supposed to be this year.
Saying that, but I haven't seen anything yet. That slide that's summarized there, that was 20 critical care specialists reviewing all of the human literature that's available and all of the veterinary literature that's available to come up with an expert opinion on how to dose the epinephrine. So it's not just something that, for example, Mallory's decided or one of the critical care specialists has decided. There's a huge amount of research that's gone into that. And again, this is another one of the things where I think many of us were initially trained to do the 1 ml per 20, the high dose epinephrine, and sometimes it's hard to untrain ourselves, especially when we're in an emergent situation and everybody is excited and trying to get the patient back. The initial thing is, oh, drop 1 ml for this 20-pound dog, but that's one of the things I want to see from you guys as technicians. We've got the ER drug sheets that you can use and kind of cheat with, but then what if this is a 10-pound cat? What's the epinephrine dose we're starting with?
0.05.
Yeah, so see, you guys know this, and as doctors, we rely on it as well. I mean, I can't tell how many times I'll double check doses with my nurses. So you can say things like, hey, do you want me to draw up the low dose epi, or do you want me to draw up 0.05 mils of epi for this cat? Like, you know, you don't have to be, what we're trying to get to the point of is a doctor doesn't have to be the leader in CPR. When we're talking about starting CPR and talking about an initial drug therapy, you know, that's something that could come from a nurse, especially if a doctor's not immediately available. And I mean, you guys know how that is. I mean, we've had it happen multiple times in a day where a doctor that's maybe involved with this case isn't available, or maybe your doctor's available, but she doesn't do CPR every day, and so she's not really sure because it's one of my patients. You know, then these are things that can be coming from you guys as well. So this is a situation that doesn't fall under the rules of diagnosing, prescribing, and treating.
Also, the patient's already dead.
True.
So vasopressin, like I said, I feel like epi is usually the first one. Obviously, it's much cheaper, and I'm sure that plays a huge role. But again, another vasopressor to help with blood pressure. It obviously affects your smooth muscle. I shouldn't say obviously, because that's not true. Affects your smooth muscle, so it helps constrict your vessels. It doesn't have any effect on the heart, though, as far as how quickly or how strongly it pumps. So it's actually really good for keeping your heart happy, if you will. It can be used in combination with epinephrine or in place of, so depending on what's available to you, depending on the response of the patient. And the cheater dose, like I said, is up here. Atropine, this one essentially its function is to basically just increase your heart rate. So it's going to be most effective in patients that have asystole, or PEA is pulseless electrical activity. And usually these situations are going to be under anesthesia or patients with high vagal tone. So obviously your technical dose down here and then your cheater dose up here. So what I was going to say earlier when I said I'll tell you guys something in a second is understanding that these drugs alone are not going to save your patient. And essentially all you're doing is putting these drugs in the patient's body so that if the patient does achieve return of spontaneous circulation, those drugs are already there to jump in and start working. You might have a little bit of like vasoconstriction, I suppose, when you're doing your CPR efforts, but honestly, these drugs are not going to work for your patients whatsoever without chest compressions or ventilation, assuming that your patient has truly experienced cardiac arrest. Intratracheal drug delivery, this is something that we use when we, for whatever reason, cannot get IV access or intraosseous access. Your red rubber tube should be longer than your endotracheal tube. And the reason being is that you don't want to deliver your drug to the inside of your endotracheal tube. Usually these drugs are actually increased in doses of up to 10 times, especially I think in the case of epi, of the standard doses, but they all can go in the endotracheal tube. The other thing too that's really important for this though is make sure that you're diluting the drug in a good amount of sterile water or sterile saline, and not because the drug is going to be too potent, but just so that you are able to cover a larger surface area. And we do flush them afterwards just to make sure everything's going down.
And that's on the ER drug sheet.
Yes.
Another reason.
Endotracheal drugs are on the ER drug sheet. Yes, Alicia?
If you have a patient that's in like some kind of respiratory failure where when you start, they start pouring fluid out of their mouth, do you need to increase the amount of medication you put in there to compensate the amount of fluid in the lungs?
I would
no
bet
idea.
that
I
it's
defer
not
to-
going to work in that patient.
I mean, that's what I think.
Yeah, I mean, in those patients, we're going to suction them, or at least try to get to suctioning them as quick as possible. But the lung is actually really good for absorbing drugs, but if there's diseased lung, then the whole diffusion impairment is going to take effect, and you're not going to see those drugs diffuse. So we would definitely still try it if we couldn't get IV access, but I think it would be very limited success.
All of our patients, when we do CPR, are always hooked up to an ECG, and it's important. It's going to be hard because when you're actually doing chest compressions, it's going to be full of a bunch of nonsense. But it's sort of nice to have as a backup to keep an eye on your patient, right? So it's really important and really effective when you're actually swapping out compressors as well, just to keep an eye on the rhythm. Is there something that we missed? Are there complex abnormalities that we could potentially treat? Do we have a heart rate and maybe we just need some more atropine? Is the dog fibrillating? That sort of thing. Or cat. So jumping to the defibrillator, there's actually only two rhythms that are shockable, right? So just because you have a patient that's not responding to CPR does not mean they're a candidate for the defibrillator. Essentially, basically, the defibrillator sort of reorganizes the energy and the electrical impulses within the heart and sort of gets them back in order. The two shockable rhythms that we have are ventricular fibrillation, right? So when you have your crazy lines all over your ECG, or when you have pulseless ventricular tachycardia. And the idea is very similar as when we have patients that are in VTAC, like regular VTAC, right? So VPCs they're not great, but we don't become super scared about them unless the rate is so high to the point where their cardiac output is affected. So just some sort of like an overview of it. There's an initial dose there for you guys. The paddle should be on either side of the chest, and this requires the patient to be in dorsal recumbency. I'll be honest, it's going to be like a serious mess. Someone's gonna have to be doing compressions while someone's also shaving, and it's usually the worst hack job, and there's so much clipper burn as a result. But you guys cannot defibrillate through the hair. A, your contact's gonna be crap, but also B, you might singe the pet a little bit. So lots of gel and no alcohol. Make sure that nobody is in contact with the patient or the table. Usually the person that's actually going to be defibrillating will say clear or here I go or whatever your word is. And then as soon as you defibrillate, once the charge has been released, put the patient back on its side or keep it on its back if it's a bulldog and go immediately back to your cycles. Once you're done with a cycle, then you can reevaluate, repeat if necessary. So this is the little chart that's at the bottom of your handouts there. So side note, this is probably Hala's favorite slide of the whole thing. Steroids, they do have a place, absolutely, but not in CPR. And oftentimes we're realizing that there are more detrimental effects to using them as opposed to not. So a couple little side things, and then I think the very last thing I have to talk about is just the team approach to CPR, which Hala briefly mentioned. End-tidal CO2, like Hala had mentioned earlier, it's not gonna make or break your CPR efforts, but it can be a good guide. So this EMA thing that we have in the crash cart upstairs, or your end-tidal CO2 on a SurgiVet in surgery or any other procedure, this gizmo just reads your end-tidal CO2. So your normal should be like 35 to 45, right? If you guys are getting readings of greater than 20 on any type of end-tidal CO2 gizmo, it's just giving you the indication that you're doing an awesome job with compressions, and that your likelihood of getting this patient back is actually better. So just a few last things to think about. Actually, IV fluids, I feel like IV fluids are a first thought for a lot of things, but in patients that have acute arrest, especially those that were completely fine beforehand, right? They haven't been sick for 5 days or what have you. Maybe they just got hit by a car. IV fluids are actually not indicated in patients that are euvolemic or they have normal hydration status. Certainly if they're hypovolemic, absolutely. Blood transfusion, I think Hala, you mentioned this earlier. Patients that have just had significant trauma, does the patient need a blood transfusion and that's why it's teetering on trying to arrest or has it arrested? If you have a really high potassium, you're blocked CATs, is that patient at risk of arrest or has it arrested as a result of that? The same with really low calcium. So like I said, this is the very last part of it, and this is what Hala had mentioned earlier. So I also really want you guys to remember that when someone calls stat to the lobby and a CPR code comes back, that does not mean we need 47 people to do CPR. It's a little bit, it depends on what all we need, so I feel like there's no right or wrong answer, but you guys I'm sure have noticed that too many people is too many people. People are in the way. It's too much. So the ideal team is about 3 to 5. I feel like 3 is a little bit too few, but it can be done, especially with experienced people. So the team leader is really important. That's often the doctor, but it doesn't have to be. The compressor, the person that's doing chest compressions, the person that's intubating and ultimately giving breaths, the person that's placing an IV catheter and then ultimately giving drugs, and the recorder is really important. During a CPR code, as you guys probably know, the roles can switch, right? So where's it at? Compressor is gonna be swapped out pretty regularly. Sometimes the team leader, especially if it's the doctor, might leave to go talk to the owner, so someone else has to take over that. So they're not like concrete roles, and they can change, but having one person do a job and knowing that that job is being taken care of and that's who you can give your orders to is really important. So like I said, the team leader does not have to be the daytime vet. What? Does not have to be the DVM. They basically, oftentimes they're not giving orders, they're not doing the orders, they're just giving the orders. And that's really important because that allows them to step back and review the whole thing. They're not just focused on intubating the patient or placing a catheter. They're making sure that things are going right and they're being done the way that they're supposed to be. So like, hey, your chest compressions are a little bit too slow, or hey, you're breathing a little too fast, that sort of thing. The compressor, obviously, they're just going to be doing chest compressions. As I said before, the intubator and the ventilator, same sort of thing. That's their job. The person that's responsible for IV access and drugs can also be helpful in doing intratracheal drugs if you're not able to get IV access. And another, I think this is the last thing I really want to stress to you guys, is that these CPR log sheets are really, really, really important. It's obviously important to know what times these drugs were given and what doses and what have you, especially looking back to say, hey, are we due for another dose of epi? Hey, are we due for this, or what have you? But I feel like this bottom section is never filled out, and that's really, really, really important. Most of the time, it's not an issue that it isn't, but there have been situations where owners have come back at us and they want to know who was involved, and we don't have this information. Obviously, we know that this is Tracy Moss's writing, but that's all we got.
Sometimes too, it might be something like vasopressin was used, and we just don't know how much was used, or it wasn't charged out, and it's something simple like that. Mallory's not really saying like everybody's coming back to sue us for these,
Right.
but
No.
It's important.
Or thank you cards.
Yeah, I mean, sometimes you've got 3 doctors involved, and one's talking to the owner, and you don't know who gave what when, and something was missed, or something just wasn't recorded, or we can't remember how much fluids we gave, things like that. So like, what Mallory's point is oftentimes people will write down the doctor or the 2 doctors that were involved, and then nobody cares about the team members, and that's not true. Like, all of the team members that were involved need to either put their name on there or sign off on it, so that when we have questions or when we come back, we can talk about it.
The closed loop communication, I feel like we actually do a really good job of this, but a side reminder is please don't just call out orders to anybody. Like, can somebody do this? Can somebody do this? Can somebody please get me an 18 gauge catheter? Please ask someone to do it, because most of the, I shouldn't say most, but several of the orders that are called out, no one takes responsibility for, so we have no idea what's been done, what's being worked on, what have you, and it just helps us be more organized and more concise. If you're saying, Hala, please give 0.2 mils of atropine, and I'm saying, and she's saying, I'm giving 0.2 mils of atropine, she's confirming that what I said is correct, right? Because I'm hearing it back from her. But then once she's giving it, and once she said that that's what she's doing, we're sort of double checking each other. We know that we said what we meant and we're doing what we are supposed to be doing.
And it's also good for the recorder.
Yes,
Because
true
they
story.
can't read your mind.
True story. So return of spontaneous circulation is not an endpoint, ever, 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 ever. They're gonna end up in the ICU just like this for a while. I don't want you guys to ever feel like something that you did or didn't do in a CPR code made or broke the outcome of that case. Because the likelihood that we're gonna get these patients actually out of the hospital is tiny, unfortunately. And that doesn't mean that we're not gonna get them back. This just means that these patients are actually gonna do well, they're not gonna re-arrest, and they're gonna be able to go home. So I know that CPR is really emotionally charged and people are really, it gets nuts. But don't feel like you've done something wrong or you should have done something differently. All the stuff about when they get moved into ICU, don't worry about it. We worry about that. I'm so hot and sweaty.
Don't forget the anesthesia cases though, 50% success rate of getting those patients back and getting them home. And remember that we're really good at getting patients back. I don't know if you know that. We are.
I was gonna say, is it really 50? I thought it'd be higher.
We're good at getting return of spontaneous circulation and getting these patients back to, yeah, I mean, and that's okay though, right? Because that may be a very guarded prognosis and then the owner has time to process those things. So we're really good at getting return of spontaneous circulation. That 5 to 10% is that dog or cat getting return of spontaneous circulation back and then surviving to go home. But I will never forget, and if you do this long enough, there are cases that stand out. Fidel and I had a case when, probably the first year or 2 I was here, that was an aortic joyful case. We had been doing CPR on it for 20 minutes. I'll admit, and all of us, we were done. We didn't think that that patient was going to come back. I was rotating brand new people through to practice compressions on that dog, and we were bolusing blood. And after like 25 minutes, that dog had returned to spontaneous circulation, and that dog survived. I mean, I will never, you don't forget cases like that. We had
Everything from step one
yeah.
was done wrong. We did not start CPR, we ran to the room to get permission. There was not one thing that we started right on that.
Bolusing blood was actually the thing that probably brought that dog back.
Right.
So that's okay. Bolusing blood is okay. Don't ask Dr. Latra. Bolusing blood is okay in a patient that is arrested and needs blood. It's okay to bolus. And then there was another case, I think probably the first year I was here with Dr. Riggs, that was a routine case that had a small little mass being removed on its leg, and that dog arrested in the pre-op area. And we got that dog back, and we ended up having to defibrillate that dog. And those ones stand out too. When you get that patient back, you have to use the defibrillator, and you shock them back to a perfusing rhythm, and that patient survived. I mean, so yes, I don't have thousands of cases, but it doesn't matter. That one case, that stands out. That case mattered to that patient. And
Please, during CPR, don't ever say, why are we doing this?
Yeah.
This patient isn't gonna make it. Please, be positive. Everybody.
you can all say, because Hallahan said, we're practicing for those patients that we can get back and the patients that we should get back, and we need to make sure that we're working together as a team. I hear doctors with questions back there. Mallory.
Fly's hand was up first.
Mallory, three points that I think we need to emphasize is that everyone, it should be mandatory for everyone to go through the crash cart and familiarize themselves with what's in there. Secondly, if you take anything out of the crash cart, if you open the crash cart drawer for any reason, do not put the tape back in the crash cart, because many times we've opened the crash cart and things are missing because someone did that. And then thirdly, you talked about defibrillation. Anytime we're doing a CPR, don't ever use alcohol for your EKG leads, because you will set your patient on fire if you defibrillate them. I saw it at CSU. It was really great. Yeah,
It's really great.
It's really great. But don't do that.
Fidel.
So, I have a question about, let's say the patient comes in and it's DOA. And sometimes we know how long it's been DOA, sometimes it's not. You have a guideline or recommendation, especially with all new people, for when is it feasible to not start CPR?
When they're in rigor. Remember that one time?
Yeah.
I know.
There's sometimes they come in the door and I'm like, I know.
I thought that was up to the doctor to make.
Yeah, I think so too.
Yeah, I think so. That's clinician discretion, and I think that's owner discretion too.
Perspective or a doubt perspective is that Mallory brought up a point about how long you can go without oxygen. People is it like 4 minutes and you've got brain damage, if that's all you've got.
And I think 6 minutes is,
Similar.
yeah. I mean, I would say it sounds silly, but if rigor has already set in, for sure. I mean, that's a discussion where that's dead on arrival. I don't think that patient is I don't think that our team should be activating CPR for that. But that example is important, because there's still literature to say that even if the patient's been down for an unknown period of time, be that 1 minute or 4 minutes, we should still be starting with low dose epi and then following up with high dose epi in those cases for the clients that still want CPR.
Because sometimes you get that phone call and they're like, we're 15 minutes away, I just found my dog, he's like blue and laying here, and you're like, okay, so
Yeah.
you're traveling.
So if it was my
15,
discretion
20
in that, then
minutes.
they arrive to the hospital 15 minutes later and the dog's dead on arrival and it's been dead in the car, like to me that would be a discussion with the doctor going in and saying that, we're, yeah.
So we talked about like the cycles and smooth transitions and not stopping your compressions for anything. At what point do you stop so that you can see if your ECG has a reading?
Yeah, that's a good question. So in the past, it used to be everybody would stop right after the defibrillator and be like, did we do it? Which is really hard not to do. So oftentimes what I will do is at least 3 cycles before I have you do like a brief pause. And then you probably have heard me do this, I say, everybody get ready, we're gonna change compressors. I want everybody to look at the EKG and see what rhythm we have. But that's also because it's a team approach, and I also want you to get used to recognizing rhythms that are shockable. So I usually will do it after typically 3. So it's about 5 minutes of CPR, because I find that by then you've had good circulation. Some people may do it differently, but it goes by so fast that you've already swapped out. Now you're on the third person swapping in, and then we look at the EKG, where I will do an active pause. Because oftentimes, like Mallory had said, if you're doing CPR, the EKG is kind of useless when you're doing CPR. The other thing is when you're doing defibrillation, that person should be going back in, or the next person in line should be going back in and doing a full, I think it's one minute cycle, right?
One cycle.
One cycle, so 2 minutes before we check the EKG. And that's because we may have shocked that dog back to a sustainable rhythm that has circulation. But remember, that dog just went from no blood circulation at all, with us being in the cardiac pump, to potentially a rhythm that has just started out, but their heart is very weak, so they still need support. And oftentimes we may even do another cycle or 2 of compressions while we're getting an epinephrine drip set up, while we're getting vasopressin set up, while we're getting more fluid set up, whatever we might be doing, because that patient during that time frame is going to be most likely to rearrest right during that time, because the epinephrine has worn off. It's only in the system for a very short period of time. Vasopressin may have worn off. So you'll see me sometimes throw some epinephrine in a bag just while we're bolusing it, because I don't have time to physically get a specific dose for that patient before it rearrests. It happens that fast. Within a few seconds you get the patient back. We don't know what to do. Sometimes we'll just do another low dose epinephrine if we're starting to see that heart rate drop down again, or atropine if we're starting to see that heart rate come down again.
I think that the picture in the very beginning with Ashley doing chest compressions, I think that dog rearrested at least 3 times. Long time. Yes.
This is it's on topic, but a little off topic. When we had that Boo Panardi, do you remember that little hound that
Boo
we were
Panardi.
walking? I was super frustrated that we didn't have appropriate drugs down the hallway. I had to run down the hallway and run all the way back with drugs. I also didn't really have appropriate monitoring equipment. We didn't have an ECG. We didn't have a capnograph. We didn't have it. I've tried going down to ER to get an ECG for an anesthetic patient, and they're labeled "Do not move ever."
Don't touch this.
So
You're not the first one that's come up.
Can we get one that's like a pet map or something that's
I think it's something we need
down
to
the hallway?
I think it's something we need to discuss with Jim, because that has come up in the surgery. So I think they're better now about having the drugs in the surgery suites, because that's one of the issues we were having in surgery.
Can we have a mini crash cart, maybe one in
I think it's easy enough.
and one down in Onco?
Yeah, Onco was one of the other places where they had talked about it, because they do a lot of sedation drugs there too. So
Running down the hall before, man, that's a long way.
I also told Jim I think we really need a walkie-talkie system directly into ICU, because when you guys need us, it's hard for us to know that. And it's not hey, I need you in 10 minutes.
Yeah.
It's you're doing a bronch and things are gone wrong quickly and you need me now.
Yeah.
And so I don't know, that's sometimes, yes, you can page into ICU, but we were trying to figure out a better way to.
I didn't even think to page overhead either.
Yeah.
I sent Diana, I was run.
And,
run,
and we don't
She's
have.
so shy, I don't think she knew who to get.
And we don't really have a system like they do in human medicine, and I don't know if I would be comfortable adapting something where they're code blue.
Yeah.
In medicine.
Overhead, it scares me.
Yeah.
People are waiting in the waiting
I don't
room.
think that would be, even if we came up with anything. Right.
Or in the reception area. You can hear
Yeah, but you
someone
can if the
like
people are in the waiting room, or if in the rooms you can hear the pages.
Yeah.
Sometimes.
So you brought up a good point, though. What would be the one piece of monitoring equipment that you're using during anesthesia that is most useful for detecting impending cardiac or respiratory arrest, and also detecting early spontaneous circulation? What's the one, if you only had one thing, blood pressure, pulse ox, end-tidal CO2, or EKG, of those 4 things, which one would you grab?
Yeah, I would choose a Doppler.
Or end-tidal.
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 End-tidal. And a lot of people don't know that, but end-tidal actually, if you were going to invest any money in those 4 pieces of equipment, especially if you have an end tidal where you can see the waveforms, you can detect. That's the number one thing. Before your blood pressure drops, before your heart rate drops, before you have arrhythmias, before anything happens, it's your end tidal that changes first. And it's your end tidal that you're monitoring CPR with, and it's your end tidal that's going to spike up when you get spontaneous circulation. And that should make sense to you guys, right? Because you have a dead patient with nothing circulating, and now all of a sudden you've got spontaneous circulation again. There's going to be a ton of CO2 buildup because there's been basically an aerobic lack of oxygen situation. And so you're going to have a huge surge of CO2 for that patient to blow off if they've had spontaneous circulation. So we should invest in a few more of those then. It's on my list.
Toolbox.
The other thing I put on there, which I think is...
Like, I think all we have for emergency drugs is atropine.
Yeah.
There's not like...
I think atropine and the three big ones. What are the three big ones I grab when I come down? Yes. So naloxone is number one for almost every single patient that's in anesthesia.
Regularly,
Yeah.
those drugs in.
So the reversal drugs, epinephrine, atropine, I think those are big. And I think it came up yesterday where we need to make sure that we have not just antecedent is a trade name, generic name?
Yeah, trade name.
And it came up yesterday where we didn't
Know what our generic
didn't
was.
know what the generic was, so we need to make sure that we're not using that terminology. So we'll need to change it on that slide because I saw it was antecedent. So, any other questions? Everybody's ready to do CPR? Yeah. So this patient, do you guys think cardiac pump or thoracic pump? Yeah. So sometimes, although our dummies are not going to be very cooperative because their limbs don't move very much. But in a large dog like a lab, usually, you're bringing the elbow back to see where the heart is. So that's where your cardiac pump would be. But remember, you kind of want to look at the chest and see where the highest part of the chest is. So that would probably, for me, be about here. Whereas if you brought the elbow back, the heart's probably about here.
Is this a real dog?
No. Okay, so this patient will say, because there's only two of you, cardiac arrested in the ICU, and because cardiac arrest happened in the ICU, we already have an IV catheter in place, so we already have IV access. And so rather than concentrate on the drugs, when you guys come up here and practice this, I just want you to concentrate on the breathing and then concentrate on the compression. So, and it's a little...
Like somebody run the dog in like it's chaos, and have the chaos, because that's the part that freaks
Yeah.
people out.
Where's that stuff, Mama?
So, Danielle, if you're going to be starting to do compressions, where are you going to start? Did you hear me say that? If this is going to be the thoracic pump theory, so you're going to go to the highest part of the chest. And because it's a big dog, you're going to do two hands. If you're about the same height as me, you're probably going to need a stool. Just depends. If you're more comfortable not using the stool, it's whatever you want. Yep. And then for him, a lot of times I will just put the patient a little bit closer to you. And sometimes I will be on my tippy toes for this. And if I feel like if I need to be on my tippy toes, then I probably need to be on a stool. Okay. So Ashley's playing the music. Mallory said we have to. Yeah. But you can actually, if you sing fast, Coppins was trying to make us go off one time just by singing this song too fast. So remember, it's about 100 to 120 compressions.
I see you.
Okay. So if you want to go ahead and start compressions, and remember this is a dummy dog, so it's a little hard. So if you guys can also assess her from there, it's hard, but she should be pushing harder. And one of the things that you can do, if any team member, you actually, if they're getting good compressions, you can feel a femoral pulse typically. And so, practice feeling for the femoral pulse in these situations. And if you haven't done compressions for a while, hopefully somebody's figuring out what 2 minutes is, because you're going to get tired real quickly. I do as well. And so the other thing you can do, how are we assessing her compressions? This is kind of very subjective. This is what's an objective way? Hurry, she's getting tired. She only has a 2-minute cycle. 2-minute cycle. End tidal, thank you. So we'd have an end tidal on, and what's our end tidal goal? Yeah, you're never really going to get greater than 20, but 15 to 20 is about usually where we're at, 15 to 20. All right, so if we're going to switch now, let's say it's been 2 minutes. You guys ready? So what do they do? Yeah. Cardiac output plummeted. So we're getting the stool out. So here's a good thing that they're doing. You guys see? Sometimes one of us is taller or shorter than the other person, so we set each other up. So someone's setting the stool up for the next person, and then you don't have to worry too much about breathing. So when you're ready, say, okay, ready, swap, and then you can swap in. Get up there, Mary Beth. Okay, so you guys are seeing what she does, and it's funny, but oftentimes that is what we do, just to get a good compression. Yep. And so ideally, we would be assessing her compressions here with end tidal. She maybe needs to go a little bit deeper, but again, in this patient, it's hard to. The most common mistake I see is this person is watching that person do compressions, and then they're breathing and breathing and breathing and breathing, and way too much, right? So you have to remember to count in your head, count to 6, breath, and remember to release it like Mallory said, count to 6, breath. How do you guys feel? I mean, this is probably like 1,001 times you've done CPR. I mean, if I can do it with a toddler punching me in the butt. Evan, are you helping Mom? No, you're so helpful. No. Oh, you're just helping and making sure her shoes stay on? Okay, good. I think that we should have Evan do it too. For all of you. I know, I love it. It's totally fine. It's life. I don't know, who's counting 2 minutes? Because if I'm the leader, I'm not usually doing my 2-minute count.
You're almost up.
And sometimes if you can't make 2 minutes, you guys have to try. If you're fatiguing, then I would take over another role. Because sometimes I will find people fatigue more than before 2 minutes is up, and that's okay. But take over a different role. And some people are really good at doing compressions, and after 2 minutes of rest, they're ready to do 2 more minutes of compressions, and that's okay too. We just do what we're best at.
Song's over.
Yep. Song's over. All right, any questions on that? We'll cycle everybody else through a little faster. This actually, for whoever asked this is to simulate the femoral pulse. So usually, on one side, it's usually supposed to work. Yeah, it's on this side. It's on the down leg.
I'm not good at this. Oh my God.
Yeah, Mal, do you want to set up the other dog?
Here, this is the other. Should I stand up here?
Yeah, I would.
The other song you can do it too.
It's like it's not like our tables, because our tables are a little bit higher. I don't feel like I can do compressions to this song. I feel like this is like.
That is the other song.
It's not funny, this is
probably.
So yeah, you're kind of in a weird like halfway. Can you go to like the other like halfway down on there? Yeah, like that might be easier, because then you can put her up against your body. You can tell the people that have been in ER, because immediately they want to like, okay, I'm ready. They want to like get up on the table.
Well, because you got to remember, though, we're used to getting on the table because the tables are up too high.
Yeah, you know. So what do you guys think about Sam's compressions? How we doing? Yeah, pretty good. You're doing nice recoil to make sure that we get refill of the heart. She's keeping her arms straight, so that's really important. Sometimes I'll see a lot of this happening, so you want to make sure you're trying to keep your arms straight. Yeah, you can cycle. I need like a 2-minute time. I need like a 2-minute timer.
I'll put on my timer. Okay, who's my team?
We're probably doing 1 minute each, and then they can cycle. All right, so one thing I would try to do is your body is like this a little bit. So try either to move this dog. Yeah.
Dog is dying.
There you go. You're better.
Okay.
Good.
Oh, that one is really weird.
And a lot of times I'm just doing it in my head.
Right.
But the thing I find the most is that this person usually is going too fast.
Yeah, because they're
You're usually staying on top.
I feel like I always go too fast.
And then the other day I had even one of the doctors involved that was like, oh, I didn't think it was 100 compressions.
And you can go right next to Sammy.
Okay,
She's ready to switch.
Okay, you ready for the next one?
Go on, Kira, let's see this. Come on.
Who's gonna breathe for
Ready?
her?
2 minutes?
Yeah.
Ready? 1, 2, start.
All right, so remember, you're 1 every 6 seconds. And you're going to need to go a little deeper in a real dog, but sometimes I know it's hard in these cases, it is. But your hand position is perfect, and you're doing a good recoil. I like that, and you're nice straight up and down. And sometimes it's hard, and you don't want to get involved when you haven't done CPR a lot, but I would try to get in them.
Stand back and record.
Yeah, and that's okay, because you learn a lot when you're recording too. And you can make sure everybody stays on board with their drugs.
I think I only watched for like the first year I was here.
Sasha got like the fastest version of it ever.
She's got that scary dog too. That dog's scary.
All right, you guys want to cycle out? How many minutes was that?
They're not even a full minute through.
Yeah, so you can see, like, you can tire out, right?
You're at almost a minute right now. Okay.
I'm not gonna lie, I'm usually the leader because I tire out real quick.
Okay, so now you're at a minute. So if you're tired,
Then you guys can.
switch out.
All right, 2 minutes, done.
And then, yep, and you might not have to use the stool. It's whatever you're comfortable with. So you have great hand position, good depth, a little more recoil. So as you come up, there you go, perfect, yep. And then a little faster compression. Yeah, good, good. And then normally, because your compressions are nice and deep, I would be feeling femoral pulse here. Nice femoral pulse. So that's actually really good. And you can practice too. Sometimes it's okay to reposition yourself or get up on the table or ask for a stool. Sometimes we'll be like, hey, can somebody grab me a stool? If you start CPR and you're like, gosh, I'm really low or really high.
Because you're like taller than me. I definitely can't do
Yeah,
that.
so when she swaps out, she's gonna ask for the stool. All right, who needs to go next?
Yeah, next.
Any questions you guys have as you're doing this, feel free to ask.
Okay, so you guys.
Yes. Yes.
Okay,
The grates.
yeah.
I don't do CPR on the grates.
Okay.
So the way that I switch out, remember our tables are a little bit higher, so I get up halfway usually on the stool, and I do it here, and I'm usually pushing the dog into my legs. Yeah, yeah, because I can't get up on the table with my knees. Like,
I get all the way up on the table.
and some people do.
Oh, no, I'm talking about the grates themselves and about how they have the more give than a standard
Oh,
table.
I see what you're saying.
Yeah, they do
Yeah.
have a little bit, yes.
Yeah.
You're right, they do have a little bit more give to that.
For those ones though,
That was one of the things that I remember being taught was
Yep.
that you shouldn't do CPR on those graded tables.
yeah, so for the most part, because we do a ton of CPR on those tables,
Right.
we're usually able to still get the compressions we need because the whole dog isn't moving down into the table because the grates are heavier duty, especially with our newer tables.
And our new ones are
Um,
one whole one.
And assessing the pulse and assessing the CO2, I find that if we have a good compressor that's getting the depth that they need to be getting and getting the recoil that they need, then usually we're not having an issue. Larger dogs, though, I will say, like a Saint Bernard or a Great Pyrenees, like those dogs should be done on the ground. And I think sometimes we need to get.
Dr. Latra and Coppins, once you put them up on
Yeah.
the table, you can tell them to go get HE.
Yeah, you can tell them Hallahan said it's better to do those patients on the ground. And I just feel like that. Like, what is the excuse though? Because it's not like you need you have an ambu bag. You've got an endotracheal tube, and then you got your ER drugs. Those can go anywhere. So those giant dogs should be done on the ground.
Because just think about it, you're wasting your time trying to get them up on the table when you need to be doing compression.
And if you're being really honest, those dogs should have open chest CPR. Those ones should be open chest, but we don't typically offer open chest here unless it's a patient that's in surgery. Yeah.
Okay.
Who wants to go with?
So, what can I do? Okay. So,
And so whatever you're comfortable with, the stool, without the stool, half the stool, on the table, it doesn't matter. You can move this over and get on the table, whatever you.
definitely feel like I would need to be.
And then I would push him, sorry, didn't mean to push him that much. Because you want to be about right there, and you want a straight arm. All right, we good?
all right, I'm timing.
So you're gonna go a little faster with your compressions. There you go, good. Good depth, even with the dummy dog, I like it. You're doing good with the recoil. You can tell though how you can get tired real fast because if you're doing them correctly, you do start to tire out. And then somebody would be checking pulse here. Oftentimes we're running to get the end tidal so that we can see if you're getting good end tidal. And if you're not, remember 50% of the chest is how much you may need to compress that chest. And it's often amazing how little trauma we cause in CPR. The most trauma we usually see is mild pulmonary contusions, although we can sometimes cause rib fractures. It's pretty uncommon, which is why Mallory had said it's important just do CPR if we feel like the patient's not breathing. And so when you get fatigued, one of the most common things to do is to bend at the elbows. So you just want to try to stay shoulder-wise.
So most people are getting fatigued at about a minute.
Yeah.
So which is fine. So then if you want to switch out, you just tell her that you want to switch. So continue doing your. All right. And remember.
And then you don't worry about the breath because you've got six seconds before you have to give another breath.
We're doing great. All right, 15 more seconds and you guys can swap.
And if you feel like you want to get up on the stool, you can. So one of the things that's easier with this stool is you have a little more downward motion than forward motion. And it's okay to stop and just kind of see what you see. So there you look way.
I don't want to be here either.
Nope, you want to be about right here. Yep. The widest part of the chest in this size of a dog. And for cats, I find that it is very hard for me to do this with cats. I fatigue very quickly with this. So I usually will do either a clam or I'll do my palm if it's a small enough patient because then I feel like I can do that. Or you might see some people take a cat like this and you can actually do like a thumb.
Yeah, like I'll sometimes put my hand underneath the chest and do a compression both ways while my hand's underneath. If somebody else is like holding the cat's back and stuff like that. So
Mal, is there any way that for the cats that we can't do? I don't think that in the literature that there is because a lot of times this part fatigues.
Tiny.
Yeah, for sure.
Super tiny.
And it also depends on how big your hands are because, you know, Dr. Snow and I have circus hands. Extra smalls around here. So it's kind of hard.
Who else? Does anybody else have to go? So everybody's understanding the importance of why the 2 minutes is really important because you can already feel yourself fatiguing at 1 minute. And you gotta, we all need to start working out and doing more CPR.
Okay, so that was a minute. You good?
Yeah.
She's like, I'm sweating. I'm usually doing CPR and I'm like, I'm sweating so bad, somebody come.
That's me on a normal day, right?
And then usually we just pray that Don's there because he's usually the master compressor.
I'll do her. Are you sure?
Okay.
Christina is also.
I know.
Okay, you ready? Ready. All right, ready? Go.
Tony, your nails look really nice during the CPR.
Those are great compressions. Those are really good. Granted, the dog's falling off the
Yeah, so
table.
try not as much recoil.
A lot of people that wanted to, but I
There you
sat
go.
down at one of them and nobody reduces much.
There you go. And once you get better at compressions, I know a lot of people are like, make sure you totally recoil, but it doesn't always have to be all the way off the chest, which you're not doing. I'm just talking out loud. You're just releasing the chest, which is perfect. And your sideline view is nice and straight. But yeah, you do get tired really quickly.
Yes, you do.
Let me see. Oh, yeah, good pulses.
Excellent. Excellent.
But some things, if you don't feel like you're getting a good pulse or you don't feel like you're getting a good end-tidal CO2, two things I feel like are the biggest ones. Increase your compressions. Three things. Reassess where you're compressing at. And also potentially make sure you're either speeding up or slowing down, because if you're not around 100 to 120 beats per minute, then that might be affecting your circulation as well. So I think those three things. How fast are you doing it? Reassess your location. The most common place, though, is depth.
You're doing great. How are you doing? How are you feeling?
I'm tired.
I'm tired. I'm tired.
Like, they're like
Just keep going.
in the
Yeah.
like,
10 seconds left.
You okay?
Keep going.
You're almost there.
I feel like this is like a physical ed like class. Climb the rope, everyone. Make sure everybody can climb the rope.
All right, switch out. I'll help you.
Mel, it's too bad that there's that 2 minute cycle, because I feel like we would all do way better with that 1 minute. We did 1 minute. We did 1 minute too, but just for real CPR. I feel like a lot of people fatigue at about a minute. And it feels like forever when you're up there compressing.
But if we can do like really smooth transitions where it's almost like not even a pause in the compressions, I feel like that's totally fine.
Yeah, you just have to have the communication and talking to people and say, okay, I'm done. Somebody come up and get
And I think that's where we are really strong with that. And if there is only one doctor and we're trying to run out to go talk to the
ICU team.
client,
You guys have to do your stuff.
yeah, a lot of times what I will do is give an order to whoever's doing CPR, like, okay, after this, if we still aren't getting the patient back, give another dose of epinephrine, and then I'll go check in or whatever. Any questions, you guys? Everybody good?
This one's easy to compress though.
I want to come see.
Can I ask a question?
Yeah.
Okay, so how you're saying how the CO2 then builds up in their body, like so it's just build up. So then that makes the blood really acidic. So then afterwards, do you give a buffer, like a?
So old school, they used to give buffers, but what they're usually doing is helping the patient blow off the CO2 with making sure they have adequate ventilation.
Okay.
And with adequate ventilation, usually it's going to correct itself.
Okay, so
Yeah.
okay.
Yeah. I will say in severe cases of acidosis, you can give bicarb, but if you talk to all three of the criticals, we were all trained at Michigan State, and none of our mentors gave it, so we really aren't taught to, we're really not taught to give it. And I think it's just because the literature doesn't really support it.
Okay.
But yeah.
Okay, thank you.
Yeah.
Have a good
Thank you.
Nice to meet you.
Nice meeting you as well.
All right. That's a wrap.